Hello, and welcome to the sixth and final presentation in the Build a Clinic program on key components of implementing tobacco-free policies, including tobacco cessation services and supports. My name is Jim Pavlik, and I am the Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus, and the Program Manager of the Build a Clinic community. The goal of today's webinar is to introduce concepts to help you fully integrate tobacco cessation services and supports and make them a regular part of whole patient care, and in integrating them in this way, ensure they become self-perpetuating, low-burden habits. Before we get too far along, I wanted to take a minute to do a bit of housekeeping. For those of you who have attended previous Build a Clinic webinars, you'll remember we have switched to a computer and internet-only webinar format. So far, this has worked out really well. Thank you so much for those who have chatted in their questions and participated in our follow-up evaluations to previous modules. Please take a moment to mute your computer's microphone. This significantly improves sound quality for all listeners, as the computer tends to clip or alter the audio when it thinks someone is about to speak, and it may also generate a distracting echo. If you do accidentally close out or get kicked off during the webinar, simply re-access the link in the confirmation email you received and rejoin us as rapidly as possible. Please send in your questions as you think of them using the chat functionality built into the webinar software. I'll do what I can to pay attention to questions as they come in, and if it's relevant at that time, I will answer it. Otherwise, I expect we will do so at the end. In any case, if you need clarification, extra resources, even if you just disagree with something that we've said, please send us a chat message and we will respond accordingly. So what are the best practices we hope that you can make a sustainable part of regular patient care? The first webinar covered the 5 A's, a clinically proven best practice used to move clients through the stages of change, motivate quit attempts, and remain abstinent longer. In the second webinar, we discussed pharmacotherapy options. Combined, these first two presentations provide the basic skills necessary to begin treating nicotine dependence right away. For the third webinar, we returned to counseling with an in-depth look at the use of motivational interviewing within the 5 A's framework. In the fourth webinar, the University of Colorado Department of Family Medicine discussed how tobacco cessation fits into a typical clinical workflow to find low-burden ways to integrate tobacco cessation interventions into existing practice. Last time, we introduced the whys and hows of tailoring tobacco cessation interventions for populations specifically targeted by the tobacco industry, and those populations that, although maybe not specifically targeted, tend to lack the preponderance of services that frequently lead to more successful quit attempts. That presentation focused on cultural sensitivity and how the use of pre-established protocols combined with motivational interviewing can make clinicians more adaptive in the face of our increasingly more diverse and ever-shifting populations. Today, we will look at habituating the delivery of these services in such a way so as to create a sustainable culture of wellness. The first 5 webinars in this series are already available as videos on our YouTube channel. You can access them easily by visiting our website, bhwellness.org. Look under the Materials tab and then select Build a Clinic Materials. Today's webinar, like all Build a Clinic webinars, will be available on that page 2 weeks from the broadcast date. My name is Jim Pavlik, and I am the Program and Policy Analyst for the Behavioral Health and Wellness Program. In that role, I perform 2 separate but related duties. Primarily, I'm responsible for much of our internal program evaluation, and I assist our research team in designing program evaluations for our clients and partners. I'm also one of our lead consultants, helping our clients develop and execute tobacco-free programming, whether that's client-focused cessation services and supports or staff-focused. I'm also one of the principal authors of our tobacco-free policy toolkit. Today, we have 2 main objectives: to learn strategies to scale and sustain your agency's tobacco-free services and to address some common concerns regarding sustainability. In order to achieve these objectives, we need to have a basic understanding of what is meant when we say scalability and sustainability. A program or suite of services is scalable if it is designed in such a way that it can be made larger, scaled up, or smaller, scaled down. For example, a program in a single small clinic may only require 1 person to handle the tobacco-related intake questions, use them to assess the patient's dependence, counsel them, advise them on potential pharmacotherapy options, refer them to various specialists, and follow up with them. However, a large clinic may require that these roles be broken up between 4, 5, or more individual staffers and clinicians. The program is scalable if these tasks are described and divided up in such a way that those who would like to translate the program to a larger setting can readily do so. Which characteristics are required to make a program scalable vary widely within the context in which they are to be scaled into. So I'll spend most of this webinar looking at sustainability, because for the most part, sustainable programs tend to be scalable more than scalable programs tend to be sustainable. Very many large programs can be sustained with an overabundance of resources. Sustainable programs have two things in common. The actions that comprise the program are easy to do, and the resources are maximized around reducing waste. In fact, if we think of the cognitive effort involved in performing difficult tasks, we can reframe the entire idea of sustainability down to efficiency. But since I did mention funding, I want to digress briefly to note that tobacco cessation programming isn't free, although for most organizations, and especially those in high needs areas, they'll tend to see beneficial return on investment down the road. Nevertheless, funding is a perennial concern of those that implement these programs. But funding sources come and go and vary widely between geographies and across time. As a result, this presentation does not focus on funding, although we touch on it a bit. The most sustainable programs will always be those that do the most with the least time, the least thinking, and the least money. We can sustain very many wasteful programs with unlimited resources. That's not the goal of this presentation. And one more final note here in the prelude to our content. We have touched on this back regularly throughout the Build a Clinic modules, but it's worth reiterating. People want to quit tobacco. The results shown here are from a community of practice in which we served as faculty and evaluators. We asked enrolled clients at 7 sites across multiple counties in Florida enrolled in a substance abuse treatment facility if they smoked and if they wanted to quit. And as you can see, even in these settings where the smoking prevalence rate was over 70%, the vast majority of clients either were not actively using, 31%, or they wanted to quit within the next 6 months, 44%. Only 25% were current users with no desire to quit. We'll return to this point later. Okay, so what I'm about to say may be a little weird, but bear with me. When we think of ourselves as people, we tend to think of ourselves from the brain down. The mind, and thus our identity, are caged in the brain, and the rest of our organs, cells, amino acids, and hormones, and all the rest, they're all in service of building, protecting, and sustaining this identity that reigns over the rest. But the brain, and specifically the part of our brain we most associate with identity formation, the exercise of free will and choice, they developed last. And it got here, that area, essentially by way of trial and error. Now I want you to pause for a second and think about your organization as an organism. Think about the practices you engage in. Not you specifically necessarily, but the practice as a unit. There's nothing predetermined, nothing fated about any process or set of processes in your organization. There was a sort of intuitive best way to achieve each goal that your clinic set out to reach, and how those individual best ways all fit together was determined by the unique skills, priorities, and goals of the original staffers that put it all together. Every new process that has since been adopted has also been adapted to fit into the existing structure, whatever it was. Sometimes new processes, like adopting electronic health records, have been massive in their impact on pre-existing structures. Others, like adding a new question to that EHR, have been far easier. And one way, so the question before us is, how can we make new behaviors, more efficient behaviors with a stronger health impact on our patients? How can we make those behaviors as commonplace as the ones we already perform? And one way we emphasize to do that in the context of wellness programming, including tobacco cessation, is using a parallel process, extending all services that we would normally provide to our clients to our staff as well. If it's important that our clients find a way to de-stress, that they find a way to add physical activity into their daily life, if it's important they sleep regularly and well, then all of these things are important for our staff too. In fact, this is a very large area that healthcare providing organizations could be exploring with more frequency. That is, in almost every case you can think of, if you're providing it to your patients and clients, you should be providing it to your staff as well. For instance, we know that if an organization is providing nicotine cessation services to their staff, the staff are more likely to, in turn, provide those services to their patients. In other words, a process that promotes healthy behaviors to staff and clients simultaneously serves three major functions. Firstly, it makes the staff more efficient. It means they're better rested, more alert, less mistake prone, more energetic. They take fewer sick days, fewer smoke breaks, and on and on. Secondly, it removes the barrier to providing those services that is caused by feelings of hypocrisy. Staff who engage in unhealthy activities are simply less apt to want to engage clients on those topics. We know that no one is perfect. We all have vices. We all fail to reach our aspirations. We all lapse from time to time. So we know that we shouldn't let our own lifestyles prevent us from providing what we know is the best advice and the best care to our patients. But we also know from the scientific literature that this is what happens. Finally, promoting healthy lifestyles for patients and providing the signage, posters, brochures, and services to make them a reality, and promoting healthy lifestyles to staff and all the lunch and learns and contests and award ceremonies, etc., that entails, keeps healthy living, including living tobacco-free, at the forefront of everyone's mind, all the time. Its constant presence over time will become second nature. We want asking about smoking behaviors to simply be a thing that our clinicians are doing spontaneously and without having to scan a checklist to mark it off. It is extremely important to engage this parallel process, and one thing we encourage is to look at this from a position of mindfulness and developing mindfulness. This is the foundation of all the work that we do. It's really all about mindfulness and motivational interventions. To help in this regard, we do have a toolkit that I highly encourage you to download for free from our website. It says for physicians, but this actually applies to interdisciplinary providers. It's not limited to just physicians. This toolkit was created in conjunction with the Colorado Medical Society, and it has helpful activities to increase mindfulness and set wellness goals. So I want to highlight the distinction between where we just were and what this next section is about. The last section was on the importance of creating a culture of wellness, and while that can mean a lot of things, what we want you to focus on is turning your gaze inward and really helping staff to lead the most well lifestyle that they're capable of and willing to. And this means being aware of habits that lead to wellness and those that lead to its opposite. It means being deliberate in making those choices and being aware of our own internal states that allow us to make good choices and those that lead us down the path of least resistance, even when that leads to a less healthful result. Now, being able to create a culture of wellness could serve an auxiliary role in creating a culture of practice improvement. More well-rested, more energetic, less physically sick employees can be more attentive, can make better decisions, can be more reflective, and can more fully engage in the kind of creative problem solving involved in ensuring high levels of quality improvement. But for the purposes of this next section, let's try to keep them analytically distinct. So we've talked about a culture of wellness and its role in helping to support the clinical changes you've made over the course of the Build a Clinic program. And now we're talking about the emotional reality and the physical habits involved in routinely asking, what can we do better? How can we improve our provision of care to create better outcomes for our patients? An important thing to consider is that picking and choosing small goals, working toward them, failing at achieving them, adapting your approach and trying again is the way. Let me say that again. This is part of that the PDSA program that I'll talk about in a minute. Pick and choose small goals. Work toward them. You'll probably fail or come short of your aspirations. Then you will adapt your approach and try again. This is the way. Pictured here is the results from one of our previous communities of practice. We had each organization, and there were 7 of them, report on their own readiness to adopt 29 specific tobacco cessation services and supports across 9 areas. Those 29 services are depicted along the horizontal axis. The 7 agencies are along the vertical axis. And their responses are coded on a color spectrum running from light yellow to dark red, with dark red indicating that they are currently offering that service. You can clearly see that when we had them report prior to the program that each organization was only offering a few services each, and that there were no services on the immediate horizon. That's that true red color. There's only one example of it in the right square near the top. Most services were no less than at least 6 months away, and a good number of them were not even being considered. Just over 9 months later, when we had them return to the survey, it had grown significantly darker red. So how did we help those 7 agencies get there? The way we change behavior is by changing the cues and rewards associated with that behavior. And a critical component of this is the environment that the individuals find themselves in. For example, we know that when healthcare organizations go smoke-free, staff and clients more successfully quit in large part because the environment itself no longer cues or rewards them to use tobacco. For example, if smoke breaks, which reward only smokers, are turned into walking breaks, which reward everyone, there's less incentive to specifically smoke to earn the reward of being able to go outside during the day. Just like we want to change the behaviors of our patients, we also want to look at the same type of approach to our organizations. Again, thinking of our organizations as organisms. So a good exercise for your wellness committee is trying to identify what current cues and rewards are helping lock old processes in place to figure out creative ways of changing the cue, routine, reward structure. Again, not just the patient's rewards, but also staff. How can we reward staff for participating in new program-based activities? While the general approaches to tobacco cessation addressed in the first 3 modules of the Build a Clinic series have remained the same for decades, over those same decades we've seen that while effective, those strategies have not been implemented in such a way that they have been as effective among certain groups. We have found that the additional chronic stressors associated with poverty or being part of a marginalized, if not actually stigmatized group, requires that we increase the intensity and duration of the treatments, as well as modify those interventions to meet the specific cultural needs of those populations. As a result, we've seen gaps opening up between the general population and other groups. The first thing we need to do is to make sure that clinicians are extending all services to all individuals and not making assumptions about the person's willingness to quit or their ability to do so. I'm just going to give you one example of what I'm talking about here. We began this work, that is BHWP began tobacco cessation work, working with behavioral health populations where the assumption was at the time that people suffering from anxiety or depression or schizophrenia just could not quit tobacco. Their emotional or psychological barriers were just too strong, or that they would rebel against this sort of intrusion, or that the increased stress of the cessation program would actually make the problem worse. As a result of this belief, not only were these services simply not offered, they were sometimes specifically banned, or worse, their opposite, providing cigarettes, was actively promoted. But we know from talking to individuals diagnosed with a mental health or substance abuse disorder that they want to quit at the same and sometimes higher rates as the general population. And we know from the outcomes data that they can quit. And we also know from studies we've conducted ourselves that there is an important self-efficacy issue at stake here. Those with a behavioral health issue who also feel that that issue will interfere with their quit attempt have a greater chance of relapse. So on the one hand, we don't want to make assumptions about any individual's desire or ability to quit, and we want to go further and actually adopt an approach that convincingly relays to the patient that they can succeed. I'm not going to dwell on this slide too much more because we talked about this in the last module. However, it's worth noting that each of these strategies is a source of a potential measurable. When the Wellness Committee is reviewing the entrenchment of current programming and whether it is being successful, this is a great place to stop and ask, are we doing these things? Can we do them better? And when it comes to doing them better, try to think of a way to reward staff members when they engage in it. As part of the Build a Clinic module program, we have asked that you fill out our Dimensions Action Plan sheet. The Dimensions Action Plan asks you to name 2 goals. The goal should have a deadline within the next 30 to 60 days. Less than 30 days in which you've identified as a goal is probably more like an activity in service of a larger goal. And more than 60 days, then the issue is probably big enough to break down into 2 or more smaller goals. So I'll use one example that sort of works in both directions. If your goal is to organize a staff training, the first activity of that goal may be to talk to your immediate supervisor to make sure you're allowed to allot the time to planning it. You may also be asking for permission to enlist other employees outside of your immediate chain of command to help you. The training may be planned for 2 months from now, 60 days, but calling your supervisor is something you can do today. It may only take 15 minutes to an hour. It really isn't a goal in and of itself. On the flip side, if you work at a very large hospital or in a large system, and a quote unquote staff training may include 50 or 70 or more clinicians spread out over several sites or across a very large building on multiple floors, a schedule of staff training may be a bigger task than 60 days allows. It may require coordinating with several departments or line managers, catering a lunch, reserving a room, even hiring professional trainers. The trick here is to be realistic in your goals and plan accordingly. In all cases, however, use SMART goals. Be very specific about what your goal is and be specific in a way that makes it very clear whether you've succeeded or not. Use numbers. Don't say that you want to hang some posters around the clinic. Say you want to hang one poster in each of 5 waiting rooms. You should be able to accomplish each goal with the resources available to you. That doesn't mean you need to have those resources immediately in your possession. You may be able to get a grant to fund some of our work. You may be able to work with your manager or someone else to get new staff to help you achieve your goals. If new resources are easy to get, they may take a phone call or a short meeting, then by all means, plan as if you have them. However, if getting new resources is difficult and timely, or it takes time, if it requires like a full grant writing process, for example, or hiring a new staff member, then gaining this resource becomes the goal. Give yourself a deadline. This is a painful thing to do, and many people are reluctant to give themselves real deadlines to which they can be held accountable and possibly have the success or failure of their program judged by it, but do it. Certainly it adds accountability and compels individuals to work on their goals, but it also provides a means of analyzing success or failure for future planning. If a goal wasn't reached, why not? Did the board get in the way? Is working on persuading the board a new goal to adopt in order to achieve the larger goal? We recommend using SMART goals as part of an ongoing, regular PDSA program. PDSA stands for Plan, Do, Study, Act. What is your goal? What are you going to do to get there? Then you try it. If you succeed, analyze what worked. If there were obstacles, can they be removed for the next round of goal setting? Are they already gone? And then what are your new goals? The new goals could represent advancements built off of the old goals, or they may be the old goals, but revised upward or downward in light of changing circumstances or new realities. So we're going to return briefly to the idea of infrastructure and workflow. 2 modules ago, we talked about workflow as a general concept. Now I want to return to the concept of workflow analysis and redesign as a component of sustainability. Workflows, as I've already alluded to, change all the time. They tend to do so in an ad hoc way. Someone higher up says, okay, well now we're all going to do this. And then the staff in the front lines figure out a way to make that happen. However, an efficient workflow redesign insists that staff be mindful of what they're doing and why, and will consciously design systems so as to avoid redundancy and other inefficiencies while also taking advantage of existing supports and tools, including available financial supports. So the first thing we need to be aware of is for nearly all clients, tobacco cessation-related work is reimbursable. For some clients, this has always been true. Over 60% of Americans have employer-sponsored insurance plans, and many of them, over the last several years, have been adding tobacco cessation services to those plans. Most of the remainder, Medicare, Medicaid, and individual private plans, including marketplace plans, that's Affordable Care Act marketplace plans, are now required to offer tobacco cessation services because of the Affordable Care Act's Essential Health Benefit Clause. And the simplest explanation is this. The United States Preventative Services Task Force reviews all screening and testing procedures for preventative medicine every year, and then using epidemiological and etiological data on the conditions being screened or tested, makes a letter grade recommendation on the cost effectiveness and overall benefit of that intervention. Interventions receiving a grade of A or B must be covered by all insurance plans to be considered Affordable Care Act compliant. And the basic best practices for treating tobacco use have always received high marks. Unfortunately, some quirks in language have allowed what you see on this slide to be considered both the recommendation, but also an example of what should be covered. So how various insurance plans decide to cover tobacco dependence treatment has some variability. However, this is how Medicare, Medicaid, and most marketplace plans cover it, and it's how most employer-sponsored or third-party plans cover it. The big area for variation is in which and how many pharmacotherapy options the plan provides, and some state Medicaids will cover telephonic but not group counseling or vice versa, although a lot of them cover both. The key takeaway here is that, with the exception of those who still fall into the Medicaid gap or those who have decided to pay the tax penalty rather than buy health insurance, nearly everyone receives some level of support. No matter what issue your practice wants to prioritize or set of issues, tobacco use has an important part to play in it. Tobacco work is heart disease prevention and management. Tobacco work is diabetes management. Tobacco work is alcohol dependence recovery. Tobacco work is social justice, housing justice, and employee training. For service level workers and construction workers, it is labor and environmental justice. It is budget management, and it's economic justice. So it doesn't really matter if your main focus is life skills education, wellness instruction, cognitive behavioral therapy, motivational interviewing, or respiratory therapy. Your work is deeply tied to tobacco work, and your patient success is deeply tied to their nicotine dependence. The bottom line here is not to think about the services you provide as piecemeal offerings, but rather as part of an entire system of effective, safe care delivered by a well-performing workforce that is responsive to all aspects of the client's wellness, and where activated, informed clients work together with a healthcare team to make decisions. And the client's relationship with tobacco is a critical element of making the right decisions. Pictured here is a whole health workflow, because we know that you're already working with clients on diet and exercise as a means of caring for some of the most prevalent chronic illnesses like heart disease and diabetes. This workflow was designed with traditional chronic care model in mind. My guess is that with fairly little effort, you could either redraw this workflow to match what happens in your clinic, or with very little effort, change what happens in your clinic to match this workflow. And in either case, once you've done that, you can do this. We don't want you to put tobacco in a silo because it isn't in a silo. In addition to treating the whole patient, the HWP envisions a whole clinic approach to tobacco dependence treatment where the entire 5 A's plus motivational interviewing process is divided up in such a way as to distribute the burden providing that care across the workflow. Clients enter the building and go into a waiting area where there are educational materials in place, including pamphlets, posters, and maybe even an instructional how to quit kit. Also on prominent display is the phone number to the state Quitline. If applicable, you want it prominently placed that this is a tobacco-free facility, and maybe even your organizational values or a statement with your commitment to wellness and recovery. These are all self-reinforcing elements. Obviously, if you work with a lot of patients speaking an alternative language to English, you would want these materials available in whatever languages make the most sense. From the waiting area, the client goes to intake. Different organizations have different people performing these roles. It's fairly typical for the patient to fill out a form and have a secondary period where an intake specialist asks a different set of questions and adds them to the initial set. Your intake specialist may, in fact, be empowered to make initial diagnoses to help direct the patient to the most appropriate clinician. At this point, the patient has moved from the waiting area and perhaps from the intake area, if these are separate, and into a more private space. Once again, we have posters on the wall and perhaps educational materials on display. The clinician, using a motivational interviewing approach, will walk through the 5 A's and perhaps move the client to a peer provider or patient navigator to connect them with community services. That's in the bottom left of the blue area. Or the patient is then moved to a physician who will repeat the advice to quit in a non-judgmental way. In some cases, this may be a psychiatrist or a psych nurse rather than a physician. This person will look at the assessment of dependence and make a prescription or a recommendation and also recommend a follow-up appointment. Perhaps record this follow-up and any necessary reminders into the EHR. At this point, the prescribing authority returns the patient to the initial clinician or to the peer support or patient navigator to continue assisting the client, perhaps by providing any necessary pre-authorizations or referrals to other professionals. This may be the person who will make the follow-up call. And then finally back out to billing, where the billing specialist will note the tobacco interventions that were applied, and they will be recorded so the clinic can be reimbursed. Now, I've gone through this as a tobacco workflow, but it should be obvious that I've not added any new roles or processes with the possible exception of a peer or patient navigator. No matter what, the patient's going to talk to somebody for their intake process. No matter what, the client's going to talk to some clinician. Many clients will be there in need of medications, and you probably have someone on staff charged with that responsibility. And no matter what, there is someone in charge of billing. A few additional questions and a new class of medications to prescribe are the only real differences here, and some new educational materials on prominent display. Now, don't hate me. One of the things I hope you're hearing me say a lot is that tobacco work is the work you've been doing for years. Tobacco work cannot be put into a silo. It's all the same work. Your workflow, whatever it is, has evolved as your organization has evolved. Changes have occurred as part of a natural process, either because of adding new team members with new skills or to respond to a crisis of performance or some dramatic shift in your treatment population. The adaptive, that is to say, evolutionary nature of your current workflow provides a sense of comfort, a sense of rightness that it is hard to combat by appeals to reason. But a rationally considered and artificially applied modification is harder to sustain. So one thing that needs to be done is an analysis of your actual workflow so that as few adjustments as possible need to be made. What are the likely pathways a client will travel once they enter your facility for treatment? In our experience, one specific pathway, one specific named pathway, will more or less describe what 80% of how your clients engage with your practice. The important part is making sure that at each point of contact along the way, each person knows what their role is regarding tobacco. These roles need to be explicitly named, made clear, and if at all possible, some sort of evaluation should be implemented to make sure that clinicians are fulfilling these roles. That's not to say to punish them or to determine their raises, but in order to track their performance. The way the delivery of clinical care is organized can help ensure that tobacco use screening and treatment are effectively, efficiently, and routinely integrated into care. Areas of the delivery system that may require systems change include team member roles. A critical component of delivery system design is dedicating staff and assigning members of the healthcare team to specific roles related to tobacco screening and treatment. For example, a medical assistant may collect tobacco use status. A nurse may assess readiness to quit or link interested patients with treatment resources. A physician may advise patients to quit and discuss treatment options. Clinical workflow. Developing a clinical workflow for the intervention is also important. I've already shown you one example of a possible workflow design. You may need to adapt this workflow to best leverage the passion, skills, and talents in your clinic. Follow-up. In tobacco cessation interventions, patient follow-up has increasingly become integrated into tobacco-related quality measures in healthcare systems. Follow-up may occur in the clinic or in conjunction with an outside referral resource like a tobacco Quitline or an in-person counseling or coaching program. Follow-up may also be needed between healthcare systems. For example, a doctor's office can refer a patient who wants to quit smoking to the state Quitline and can receive a report from the Quitline on the services the patient received and on outcomes. Performance feedback for clinicians. Clinicians should receive routine feedback about their performance and implementation of tobacco cessation interventions, drawing on data from chart audits, electronic health records, and computerized patient databases. Like other chronic illnesses, treating tobacco dependence benefits from the inclusion of a tobacco registry. A tobacco registry can simply track the use of the tobacco dependence best practices, or it can be more complex, tying tobacco use into other areas of care and emphasizing the web of effects that tobacco use has on overall health. For example, smokers are at a greater risk of several respiratory infections, including influenza, tuberculosis, and 23 pneumococcal diseases. With the tobacco registry in place, if a patient says they smoke, in addition to triggering the tobacco cessation interventions, it can also trigger the practitioner to double check that the patient has received a recent pneumococcal polysaccharide vaccine. And if not, to prompt the patient to receive one along with an explanation that smoking increases their chance for developing these diseases. In other words, we are providing more tailored and more comprehensive care, and we are reinforcing the rationale to quit. Another reason we want you to engage in this work is because it's becoming a standard measure of care provision across systems. Most of the Build a Clinic participants have an official designation from the Health Resources and Services Administration, HRSA. So you're all aware already of the uniform data measure that tracks the number of patients who have been assessed for tobacco use and provided an intervention. Those of you who are currently unaware of the Uniform Data System should be aware that HRSA, like many funding, accrediting, or licensing organizations, are increasingly adding tobacco intervention measures to their requirements. And the primary way that they are confirming adherence to those standards are through the reports generated automatically or by request through electronic health records and general health information technology pieces. What gets measured gets done. Standardized outcomes should be used to assess movement toward cessation and treatment goals. Since you work within a healthcare agency, you know outcome measurement starts at the first visit. One of the points we've been trying to make across the course of the Build a Clinic program is that your staff needs to know why they are recording this information. Occasional reports on demographic makeup, annual goal setting, performance evaluations, wherever makes sense to you. This slide is intended to say, once an EHR is in place, that data collection becomes a part of standardized practice. And that's a good thing. I'm adding that you can reduce employee dissatisfaction with cumbersome data collection by occasionally reminding them of the importance of this data in terms of better serving the clients and tying that to their personal values and the organizational mission. One thing to consider with EHRs is the appropriate use of stop screens. That is, a screen that cannot be advanced until a certain question is answered. In some ways, these are great, as they ensure that our data sets are complete. On the other hand, they can slow the data gathering process down and frustrate users, especially when there are legitimate reasons, with unconscious patients, for example, that certain fields must be left blank. Definitely work with the staff that are required to use the EHR system to make any changes so that the appropriate balance between comprehensive, meaningful data and user friendliness can be obtained. And finally, you want to make sure that you're adding diagnosis codes to your EHR treatment planning and billing processes. You want the codes to be specific and their use to be consistent. This makes it more likely you'll be reimbursed for those services and thus more likely that they will be done. And finally, in this presentation, I want to spend some time talking about collaborations you can make within larger systems and across systems. Basically, not only are you not in this alone, but trying to go it alone isn't as good at getting effective quit attempts as helping your patients understand that they reside within a complex network of care. The trend lately is to find new ways to integrate mental and medical care, and tobacco cessation strategies are a great way to begin or further any integration efforts you already have underway. And this is even more true with low SES and other hardcore smoking groups, because as a group, they have a greater tendency to suffer from single and multiple comorbidities. Many of them are either caused or exacerbated by their tobacco use. A lot of what follows from this fundamental idea of integrating care not just across illnesses, but across service providing groups, and not just healthcare providing groups. There are all kinds of innovative partnerships out there waiting to be formed. The bottom line is that integration is the new normal. If everyone is speaking the same language, promoting similar services, and working to develop strong communications between organizations, we're far less likely to have someone fall between the cracks. Integration means creating a system that recognizes that patients are more than the sum of their diagnoses and that true recovery doesn't stop once a patient reaches a point where they are asymptomatic. True recovery means leading the most meaningful life possible and includes developing a robustness in their coping capacity so they can effectively and spontaneously respond to new challenges when they're no longer in our care. This is important because we know that half of all tobacco users will try to quit within the next 12 months, but we don't know when that will be. Will they be with us, with someone else? Developing internal clinical practices to follow individual patients through the various points of contact is an essential first step to making sure that we're there for them at the moment they need us. And that step should be followed by developing specific outreach practices to other points the patient will contact on their journey to a tobacco-free life. An individual is complex with many interrelated systems and roles. Clinics are complex organisms, and the larger healthcare delivery system is also complex, and we are rapidly moving into an area where we are understanding that health involves more than a patient's relationship with their PCP. We now understand, for example, that personal behaviors like smoking account for 40% of premature deaths. Another 30% is associated with the patient's genetic composition. Personal circumstances are responsible for another 15%, and 5% comes from environmental exposures. This leaves 10% of premature deaths directly connected to the quality of care someone receives in a hospital or clinic. Nevertheless, we know that a smoker's first encounter with the larger health system, and sometimes their only exposure to it, is through their primary care provider. Primary care doctors and nurses hold a high esteem among patients, a deserving one to be sure. And as such, their advice is more highly valued. And so the PCP's role in the center of a medical home is justified, as is their leadership role in the patient's medical neighborhood, that collection of services that influences the patient's safety and security at home, in the community, at work, and everywhere else. Which naturally returns us to the 5 A's. In order to know what services a patient needs to help them successfully quit, we first need to know that they're using tobacco. Let them know that quitting is the best thing they can do for themselves, and then refer them to the services that they need to help them. And here we don't necessarily mean just tobacco-related services. It could be the case that housing or food insecurity is adding to the stress that causes the patient to relapse. So a comprehensive referral system will try to assess why that patient uses tobacco and refer them to the resources that they need to quit. Now, I say that we don't just mean tobacco services, but of course we do also mean tobacco services. The Quitline is a great place to refer clients to. We push the Quitline pretty hard here, and we take some grief for that sometimes. Success rates for Quitlines are as high as other sorts of counseling, sometimes as high as 25 to 30% of callers to the Quitline will successfully remain abstinent for 60 days or more, and that's an incredible figure. But that still means that 70% of callers will relapse. And that means that there are always going to be a lot more stories about how or why the Quitline didn't work for this or that person. And that's true. Obviously, we want the Quitline to be 100% effective. And we actually work pretty closely with our Quitline here in Colorado to try and make it more effective. But for many clients, the Quitline just isn't a good fit. But for other patients, the Quitline will work. And for some clients, the Quitline may be their only option for outside help. We don't want to deprive any patient of this opportunity. In fact, we need to do the reverse. Despite the fact that we know the Quitline doesn't help every single caller to quit, we want our referral to the Quitline to be an enthusiastic one. Because we know that the PCP's advice is held in high esteem, and because we know that believing that something will work can help it actually work. If the doctor provides an unenthusiastic recommendation, one that comes with a cynical prediction of whether it will work or not, it can actually poison the well and become a self-fulfilling prophecy of failure. If your state's Quitline has an e-referral option, we highly recommend getting your clinic on board. For one thing, it makes the referral process a lot easier, which makes it more likely it will be done. The other thing is that it reduces the chance for user error. 65% of Quitline referrals result in being written off as no contact. That is, the Quitline will call the patient's phone number they were given a certain number of times, like 5 times. If the person doesn't answer, or if the person who answers says it's the wrong number, that patient's account is closed as no contact. We can reduce the number of wrong numbers by removing the variability of handwriting from the process. So when we talk about these medical neighborhoods and connecting patients to other types of service providers to help their quit attempt, it is also the case that you, as a clinic or as a practice, should be reaching out to some of these other systems yourself. And the one we want to emphasize the most is reaching out to your local public health agency or your state health agency. Local and state public health can provide training and education to staff, and sometimes education or counseling directly to your patients. When local public health doesn't provide services directly, they often know who is offering those services where and when. For example, where a local tobacco recovery support group may already be meeting. And sometimes they can connect you to funding for your tobacco-related initiatives. And another part of this, again, tied mostly to the use of EHR, but not necessarily so, is finding ways to allow the wellness-related values of the agency to follow the client home. We need clients to take control of their own wellness because they will spend most of their lives not in our offices. Self-management supports includes compassionate patient-centered care, focus on prevention and care management, involving the patient in goal setting, cultural competence, education, and skills training. Patient-centered care can be defined as 1, providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. And 2, the experience of transparency, individualization, recognition, respect, dignity, choice in all matters without exception, related to one's person, circumstances, and relationships with healthcare. That's really wordy, and I apologize. So let me boil that down into tobacco language. There are a lot of reasons someone chose to smoke and continues to smoke, and we should be respectful of those reasons. People have complicated and ambivalent thoughts about quitting, and we have to be sure not to inspire resistance by insisting that quitting is definitely the best thing for them and making them feel judged or helpless by their inability to see that. On the flip side, we shouldn't just assume that because someone is old, African American, low income, low education, Native American, or LGBTQ, that they don't want to try. We don't want to make that assumption for them because this is about self-management. Everyone should be educated that help is available if they want it and invited to avail themselves of it. Finally, and this part is built into the 5 A's, is making sure the patient understands that addressing their tobacco use is a perpetual and important part of their overall health. Quitting tobacco is the most important thing a person can do to increase their health now and ongoing into the future. And the earlier they quit, the sooner they see their results and the better outcomes they enjoy. Maintaining their quit requires practice and support. So following up with them on this issue is a critical component of their success. And a low-cost way to perform that guidance, education, and follow-up is to use peers from the patient's community who have an intuitive sense of what the patient is going through and how to verbalize the advice in a way that resonates with them. We've already shared the tools on the Build a Clinic materials page, and if you haven't downloaded them yet, I definitely encourage you to do so and to use them as discussion points at your wellness committee meetings. We also have a lot more tools you can download from the resources section of our website. If you don't see a specific toolkit or addendum that you think you need, let us know. There's a possibility we know of a good one, or we might be able to put something together for you. If you haven't already, we definitely encourage you to become a member of the National Behavioral Health Network for Tobacco and Cancer Control. This network, put together by the National Council for Behavioral Health, is a great resource for continuing education, news, tools, etc., that you may need to help improve patient outcomes. Patients who exist at the intersection of these 3 areas: behavioral health, cancer, and tobacco use. And another strategy is to get your office champions, your tobacco champions, trained up as a TTS. We run 2 4-day certification courses each year. The next one is in May. We are one of 13 or so accredited organizations offering TTS certification. If our dates are inconvenient, or if you just hate beautiful, awe-inspiring landscapes, you can check out the Attude website for a calendar of other TTS opportunities. That's Attude, attud.org. So one of the key things that we found with other learning communities that we've been a part of, and that I assume you've experienced as part of the Build a Clinic program, is that adding tobacco services can cause a lot of anticipatory anxiety. I've sat around a lot of boardroom tables playing what if with senior leadership. We can imagine an infinite amount of potential difficulties preventing these services from working or being appropriately applied or reaching the right audience. But we only need to focus on the problems that we actually face. Basically, we can't improve a process until we have a process to work with. So just getting started is key. Do something now. Success begets success. Stagnation begets trepidation. Wherever you want to end up, figure out the smallest step you can take in that direction and just do it. Also, we've learned about the idea of spreading the burden of care across systems and across players within systems. Not only does this ensure that no one person is responsible for everything, it also means expanding the scope of new idea creation so that you can do a lot more spontaneous, on-the-spot problem solving. This also keeps tobacco cessation on the priority list at multiple organizations or at multiple points down a workflow. This reinforces the message that tobacco is an important issue, causing negative consequences across multiple dimensions of an individual's life. We should plan for barriers whenever we can, but we need to plan in the beginning to make systems that are robust in the face of unforeseen challenges. Staff changes are a common problem. People quit, people get fired, and if the entirety of a project rests with the peculiar passions or skill sets of one person, then the program becomes gravely endangered if that person leaves for any reason. Whatever services or supports you add, find ways to make sure they are sustainable, sustainable in the face of staff changes, sustainable in the face of shifting organizational priorities, sustainable in the face of inconsistent funding. If you ever have to pause before pushing forward again with your plan, it'll be nicer to start from where you left off and as much as possible avoid the one step back aspect of the 2 steps forward and 1 step back problem. And finally, it bears repeating, finding supportive partners outside your agency is critical to providing the kind of robust neighborhood-style care that our patients need. Finally, we are starting a second round beginning January 2017 of the Build a Clinic program. Deadline for applying is going to be near the end of December of this year. Thank you very much and good luck.